Hello and a very good afternoon to all our viewers from India as well as Middle East. Welcome to a brand new episode of Master Series session with our experts. Today's topic of discussion is clinical triad, three dimensions of obesity care, lifestyle medications and surgery. This will be taken up by Dr. Adnan Jamil, who's a specialist in family medicine at Burjeel Specialty Hospital in Sharjah, UAE. He is an empathetic, motivated physician having experience of over 10 years. He also have more than 5 years of experience in working in GCC, including Oman and UAE. Dr. Jamil is a skilled practitioner in managing all kinds of acute emergencies in casualty or emergency department. He is also experienced working according to international patient safety goals and standards and is involved in the re-accreditation of the Joint Commission International of Hospital. It is a pleasure to have you with us here, sir. Can we now begin the presentation?
Okay. Thanks, Jessica. Nice to be on your portal. That is Doc Plexus. So I'm Dr. Adnan Jamil. So we can start now.
Yes, sir.
Okay. So all the viewers, all my colleagues, all medical students or medical practitioner, very good afternoon from me, Dr. Adnan Jamil. As already Rashika has introduced me. So just briefly, like I'm a physician working for more than 15 years and having I have a special interest in diabetes, obesity, all that, as everybody know, as they are very connected. So, okay, let's start our today meeting, our today presentation. So just briefly in the beginning, it's like a little literature that what is obesity. Later on we will move and you will find that it's not only like a boring or only literature. We have statistics, we have new researches, we have some interactive session in between. You will find it in the later on in this presentation. So okay, so come to our presentation. Obesity is a complex chronic progressive and relapsing disease, everybody know, characterized by abnormal or excessive body fat that impairs health. Is one of the greatest global public health challenges, considering that 13% of the total population live with obesity. That is, prevalence has been tripled by 1975, and it is going on and on. So the pathogenesis is like multiple metabolic mechanical complication. Metabolic means diabetes, mainly hypertension, dyslipidemia, sleep apnea, cardiovascular disease, non-alcoholic fatty liver disease, and NAFLD, infertility, osteoarthritis, in which because of the obesity, the expectancy of life can be decreased by 5 to 20 years. We'll go to the next. Lifestyle interventions are the cornerstone for the management of obesity, but even the most intensive program is still commonly only achieve 5 to 10% weight loss, and long-term weight maintenance remains a challenge. So everybody know, like even trying to do the best, not getting the result that is required. Although 5 to 10% weight loss reduce cardiometabolic risk factors, and especially people with BMI more than 35, that is class 2 obesity and above, and to reverse some obesity related complication. And it is helping in if you lose a weight around target around at least 10%, 5 to 10%, it will sure help. And that can be, we can take the help of pharmacotherapy, medication. Even with this, weight loss is not more than 10%. So bariatric surgery was the only intervention that consistently resulted in more than 15% weight loss, and especially in the long term. The amount of weight loss led to improved quality of life. Everybody knows significant health benefits and reduced mortality. Despite the considerable benefit of the bariatric surgery, it is not feasible or scalable as a population-wide intervention, along with suitable tolerability and safety remain a challenge. Next. Okay, we can go to the next slide. Yeah, recent clinical trials with advanced therapeutic candidate, including new GLP-1 receptor agonists and dual agonists, demonstrate that the gap of sustained weight loss between bariatric surgery and pharmacotherapy is gradually closing. So it means like with the new intervention, new medications, especially GLP-1 receptor agonists that are helping to get the significant or the targeted weight loss with the help of like this pharmacotherapy in comparison to the bariatric surgery. Okay, so here we will review the available intervention for weight loss and weight maintenance with a focus on therapies for obesity approved over the last decade, as well as the emerging development of new obesity pharmacotherapies. Okay, so we will go to our next slide. Okay, so that was the introduction, brief introduction about obesity, obesity-related complication, challenges, options, whatever. Okay, so as I told, I have a special interest in diabetes, and so I have merged our topic with the diabetes because you will find very soon that how closely related is obesity and diabetes. So why even discuss obesity and diabetes together? This is a question. So our learning objective today: identify how to use obesity treatment to delay progression from pre-diabetes to type 2 diabetes, recognize why obesity treatment should begin early after the diagnosis of type 2 diabetes, recall the impact of obesity treatment on glycemic control, and identify when obesity treatment can result in remission of type 2 diabetes. So the last point is very interesting and we will discuss it later on. So next, next slide. Okay, so the burden of diabetes, it's a it is adopted from American Diabetes Association, and you can see like the colors are mentioning. So you can see in detail later on. So I can tell like 89% are overweight or have obesity. So almost 90%, and about 46% have a BMI more than 32, 39, and 15% have a BMI more than 40. This is the statistics from US, American Diabetes Association, as of 2019. So we can understand that the burden of diabetes on the population. Okay, next. Okay, the pathophysiology or pathology of this like obesity, the most important factor is like insulin resistance. So physiologically, the link between obesity and diabetes is insulin resistance. The schematic, this below lays out the pathways by which the insulin get resistant. We can see poor quality diet, energy imbalance, excessive calorie intake, and decreased physical activity lead to increased adiposity, increased visceral fat, overweight. So later on, it will all again pro-inflammatory response, decreased lipolysis that results in insulin resistance, liver increase glucose production, and muscle altered glucose uptake, and that finally will result in dysglycemia, diabetes, and obesity altogether. Okay, we'll go to the next. Okay, this picture I posted here, like someone obese, many options, what to do, not to do, surgery, medicine, exercise, diet. So for a large proportion of people with type 2 diabetes, it is actually a complication of obesity and excess weight gain. So therefore, if we are treating obesity effectively, we are having an impact on dysglycemia and improving glycemic control, and that can result in remission of type 2 diabetes. Again, this remission thing we will discuss later on. So therefore, the question that we have before, why I even discussed together obesity and diabetes. The most people with diabetes are obese, and they are closely, intimately related. Next. Okay, now we are coming to the what management intervention we can provide to obese patients, or like now we are coming to our topic, Triad. what we have, like it is pharmacology, surgery, or lifestyle intervention. So the first thing we are discussing is lifestyle intervention, and for this we can see here the first slide. The behavior modification is essential. The first thing that we have to tell our patient or someone who is obese and who is willing to like cut his weight or taking treatment or understanding the complication of obesity and all these things. So so we can start with the patient is having usually diabetes, pre-diabetes. Everybody know that the HbA1c from 5.7 to up to 6.5 is pre-diabetes, and majority of obese, I can say 80% are pre-diabetics, and the other thing is metabolic syndrome. So we know everybody, majority of obese patients are pre-diabetic and having metabolic syndrome. So healthcare providers should consider behavior medication for their patient first. Lifestyle therapy can lead to significant weight loss, which is associated with prevention of diabetes as well. So therapy works in a different way, changes how we process information, changes how we make decision, route through pattern. So this is a triangle behavior modification, which include diet and physical activity, then pharmacotherapy and surgery. And ultimately, any behavior modification intervention should be the patient's successfully decrease energy intake and increase energy expenditure over the long term. Okay, and this can be achieved by diet and physical activity. Next. Okay, diet and physical activity modification, so decrease calorie intake and diet. There are many type of diets. Some, our region is having different kind of diet, so it depends. Some research diet on which major research is on, like DASH, OmniHeart, Mediterranean, low carb, whatever, and then increase exercise frequency, intensity, time. That is most important. What is required. Next. Okay, one question: which diet should patient follows? Because it's a common question, and because all that diets, the major research was done, in our region, like subcontinent, India, Pakistan, Bangladesh, our diet is different. So the question for this is that studies has shown that dietary adherence is more predictive of the changes in weight compared to the actual diet people are assigned. One study that highlights this as the A to Z study randomized participants for four popular diets: Atkins, Ornish, Weight Watchers, or Zone diets, and compared the impact on weight loss and cardiovascular risk factor reduction. While these diets were very different, ranging from high protein, low carb to plant based, the average weight loss across all are similar. So dietary adherence score was more predictive in the mean change in weight compared to the actual diet assigned. So it means the adherence is most important. Okay, we can go to the next. I, I cannot see my face, so maybe my video is not there. So it's fine. Next. Okay, so example of strategies for dietary behavior changes, just this is a counseling part for our new practitioners. Like modify the environment. For example, do not keep fatty things or the food that can lead to the increased weight, like ice cream. Do not keep it at home. So this is one example. So that you will not eat it. Utilize adaptive strategies, slowing down eating to allow oneself to feel full and reach the point of satisfaction. Again, discourage maladaptive dietary practice, means to change the sedentary lifestyle and binge eating, what we say. And again, so our target is to increase energy expenditure, decrease sedentary time, increase exercise, that will lead to improved cardiovascular fitness and changes body composition. Activity modification, increase exercise time, frequency, intensity, or duration. So that will sure help. Next. Okay, now now we are coming to our first interaction, and our participants can play a role. So we have here Angela, and Angela had gestational diabetes with her last pregnancy 10 years ago. She had postpartum weight retention. Pre-pregnancy BMI was 27, and now it is 37, and her HbA1c is 6. So now we are coming to treating Angela. We have the options like let's say this she is your patient. She came to you for advice. So so what is the best treatment strategy to prevent type 2 diabetes? And in the same way, we can say to treat her obesity. So we have options like start on metformin, encourage her to join a gym to get more exercise, or the last option is set a plan to lose at least 7% of body weight using lifestyle modification. So I know we do not have that much time. You people can put your answer later on our website, on our this portal, and we can see. So now I hope, like, I think everybody is going with what is the right answer. So we will go to the next and find how to treat this patient. Next. Okay. So the options, everybody here. So we could treat Angela with metformin, as you know, it is recommended for considering obesity and pre-diabetes. Also, we can advise her, like, it's not a big deal to tell her to go to gym and have done exercise to weight loss. But the correct answer is the last response, which is setting up a plan to lose weight, 7% of body weight using lifestyle modification and the strategies discussed in the lesson. So I think everybody is convinced with the answer. So we'll go to the next. Okay, so now we have again a new patient, and is Robert. Robert is a 55-year-old man who completed an annual health screen through his employer. So he was recently diagnosed with type 2 diabetes. His HbA1c is 8.5, high. He reports weight gain of 50 pounds over the past 2.5 years, and his several first-degree relatives have type 2 diabetes and are on insulin. Okay, so again, this is your patient. So how you will treat Robert? So the options we have: losing 15% of his current body weight could lead to remission of his type 2 diabetes, or he will likely need to start insulin therapy, giving his family history. Or now that he has diabetes, the best way to do focus on prevention of complication. Or it is unlikely that his recent weight gain is related to his new diagnosis, given his family history. Okay, so before we answer the question, now we will go to the next and discuss our next topic. Next. Okay, this slide is very good. So it is it is showing is weight loss required for therapeutic benefit. This is something very important. So we can see for diabetes prevention, the target is 3 to 10%. For diabetes remission, that is what is diabetes remission. We'll discuss this soon. So for this, the required weight loss is 10 to 15%. Okay, and above on, it is also beneficial. So for hypertension, the target is 5 to 15%. For dyslipidemia, it's again 3 to 15%. For hyperglycemia, again it's 3 to 15%. Then again, like sleep apnea, 10%, and fatty liver, 10%, osteoarthritis, 5 to 10%, and stress and incontinence and other factor, again, the average is 10%. So the figure displays weight loss ranges examined in studies. Okay, everybody understand. So we go to the next. Okay, now we are coming to the my favorite thing that I just came to know what is diabetic remission. So in 2021, a position paper was published by a group of endocrinologists that refined the idea of diabetes remission, an A1C of less than 6.5 for at least 3 months on no anti-diabetic therapy. So even like reading this thing, it looks like something very impossible thing or something fiction, but it is reality and it can be achieved, and any practitioner like can help and such patient who will get benefit from this thing. So the two things that is helping for diabetic remission is intensive medical weight loss and bariatric surgery. Okay, next. Now we have some studies here. The first study is, I mentioned here is look ahead study. Um, examine type 2 diabetes, uh, and researchers found that some small proportion of people in the behavioral weight loss intervention group were able to achieve diabetes remission. Okay, the intensive lifestyle intervention group that we can see, the long bars, was significantly more likely to experience any remission with prevalence of 11.5% during the first year and 7.3% at year 4, compared with 2% of the DSC group at both points. So we can see here the bar, the high bar that is reaching around 11. It is those who are involved in the intensive lifestyle intervention comparison to other peoples, and uh, as they mentioned, 11%, between 7 to 11% achieve diabetic remission comparison to control. Next, our next study is the direct trial. So again, in this I have shared all the bars and slides. So we can say that the average weight loss at 1 year, 10% of body weight. This is the active intervention group, and control group 1%, or achieve remission. So 46% of the intervention group. So it's a good number. Achieve diabetic remission by losing weight around more than 15 kg. And this study was in a UK primary setting, and all the details are here. They are adhere to the low calorie diet and exercise, and they are focusing the target. The other graph, it is showing, if you can see the control, it is 0 to 1%, 2%, in comparison to the intervention group, where we can see uh, those who achieve diabetic remission is like 45% and 35% over next year. So the 2 years after the direct trial was completed, a follow-up study was done that shows maintenance of remission. In this follow-up, 36% of intervention participants had remission of type 2 diabetes, and 64% of those who sustained. So, okay, we'll go to the next. Okay, this is the last one, is the Stampede trial, and this is for the bariatric surgery. And we can see like weight changes by treatment group, medical group, we can see only 5.3 kg. Then this sleeve gastrectomy group is 18%, and RYG by is 23%. So the bar graph above contains data for participants whose A1C was less than 6.5% and not on diabetic medication, the definition of diabetes remission. Okay, so on average, around a quarter of people who are having bariatric and metabolic surgery are seeing remission of type 2 diabetes over 5 years. This is some recommend we can see, but overall it is like encouraging. And you can see through this study, and if somebody need, they can go and see in detail. Okay, next. Okay, now we are coming back to Robert. I think we forget. So just uh, we can see like that as we have gone through the details of the Robert. So there is one scenario of treatment for Robert is that, again, it is a question for everyone, that we should start Robert on metformin and sulfonylureas and the first step. Then after 2 years of his treatment, again, he had some weight gain, more than 10%. His A1C is again above target, and his regime is intensified with adding a SGLT2 inhibitor. Or the other way of treating Robert is that Robert is directed on lifestyle therapy and prescribed an FDA-approved anti-obesity medication. He find initial success, losing 10% of his weight in 4 months. His A1C decreased to 6.4%. He loses another 5% over 4 months while continuing anti-obesity medicine, and at 9 months since diagnosis, his A1C came back to 5.8%. So this is what exactly the concept of diabetic remission. So again, treating Robert, so the best answer is losing 15% of his current body weight could lead to remission of his diabetes, and all other options are not applicable or not the best choice. Okay, so we'll go to the next. Okay, now we have completed almost lifestyle intervention and diet. Pharmacotherapy, we will not go in total depth, or because it's again, it's itself a major topic and we can discuss for hours. So here I just keep some available pharmacological options. We can see there is a still debate. Some medications are approved in UK, some are not approved in UK, some are approved in US, not approved in UK. So anyway, what options we have is phentermine or listat, phentermine plus topiramate, semaglutide. Again, this is the GLP-1 agonist, liraglutide, and bupropion and naltrexone. So there is some medication. We'll go to the next. Okay, now the mainstay of nowadays regarding the medications of obesity treatment is GLP-1 agonist. And you can see all the pictures here. I will just mention in short GLP-1 incretin, stimulate insulin, inhibit glucagon, slow gastric emptying, and lower food intake as well. So in combination of all effect, lower blood sugar as well as help in weight loss. So there are some medication who are daily, like the lixisenatide and exenatide, are now weekly available, but usually before it is twice a daily. Now we have weekly injections that are more convenient to use, but again, there is what are the issues of using this. We will discuss it later on. So this is what pharmacological options we have nowadays. Next. So what the role of medications or pharmacological? So their impact on body weight compared with diet and exercise alone. Pharmacotherapy, what is the added advantage of pharmacotherapy? Increase the proportion of people achieving clinically significant weight loss by 40 to 80%. Again, increase the amount of weight loss by 3 to 14%, increase the duration of weight loss. Then again, pharmacology has three main effects: increase the number of people who respond to lifestyle intervention, increase the magnitude of the response, and increase the duration of that response. Approved pharmacotherapy options work by altering food intake and causing malabsorption, that is orlistat. Next. Okay, now we have our last patient, Rosita, 37-year-old female who experienced difficulty losing weight despite repeated attempts. Again, that issue is the common issues. Insurance doesn't cover semaglutide or GLP-1 agonist, medications, pharmacotherapy, that is the drawback or the issues facing by all the physicians. Now her BMI is 42 and it's very high. A1C is 8%. She had about 5% weight loss with semaglutide 1 milligram. Maintaining reduced calorie intake is often associated with increased craving. So now how you will treat Rosita? So what options we have? No need to change, no changes needed. Maintaining 5% body weight is good. The second is review additional ways that she can modify her lifestyle, including reducing carb and increasing activity. This is the second option. Discuss the benefit that metabolic and bariatric surgery could have for her, especially with regard to her type 2 diabetes mellitus. This is the third option. Fourth, just focus on glycemic control because she is not motivated. So now, what is the answer? What should be how to treat, and what is the best answer? So we'll go next and find what is the best answer for Rosita, or as a physician or practitioner, at least what advice we can give to such a patient. Next. Okay, now we are coming to the surgical treatment option, that is bariatric surgery. The metabolic and bariatric surgery represent the most durable and largest volume of weight loss that we can get for different treatment strategies, especially in severe diabetes, that is BMI more than 40. So there are three main diabetic surgery like options: vertical sleeve gastrectomy, Rox-en-Y, gastric bypass, and duodenal switch. So the most commonly used are the first two. Again, here the picture is very nice, and it is the last thing it is mentioning that with the treatment there is the quality of life more than 80%. It is helping reducing like treating obesity effectively, helping in quality of life up to 90%, and again mortality benefit. Next. So this is a comparison of the studies of vertical sleeve gastrectomy and Rox-en-Y gastric bypass. Mortality is 0.1%. Again, it is a main question among such cases, like surgery, cutting, surgeon, operation, all this thinking of complications. So we can see with vertical sleeve gastrectomy is only 0.1%, and with R&Y bypass is only 0.2%. Serious complication again 2.4% and 2.5%, not a big number. Complication 6% to 10%. Response 25% weight loss. Okay, and about 49% achieve A1C less than 7 in Stampede trial at 5 years with the vertical sleeve gastrectomy, and 51% achieve diabetic remission, that is diabetic remission almost, and with 30% weight loss in R and Y group. Okay, next. So treating Rosita, now we are coming to the answer. So the best answer for her is discuss the benefit that metabolic and bariatric surgery could have for her, especially with regard to her type 2 diabetes. So this is what advice as a physician and a practitioner we should give to any patient with BMI more than 40% and who already tried all the options like lifestyle intervention and low calorie diet or all these things. So this is the last resort, and sure the benefits are much higher than expectation, hopefully. Next. Okay, now this is our last slide. So again, the last thing we just discuss, like what are, it's very easy to speak and guide and counsel patients for obesity, like, but to keep the patients or people adhere with the target plans, everything, many issues are there, social issues are there. Then again, one of the main issues is that the insurance is not supporting all these medications, GLP-1 agonists, if you compare it as a treatment for obesity, so they are not covered. Only in case of diabetes it can be covered, but if you want to treat obesity, it's usually 80% insurance is not covering the medication and they are high cost. So this is one issue. Obesity bias and stigmata, social and other issues, and lack of provider trainer education, that is also an issue, like which patient what should we advise, as we discussed in the previous slide. So I'm just conclude with the key concept. So type 2 diabetes is a complication of obesity, and again obesity we can say is a complication of type 2 diabetes. Therefore treating obesity is treating dysglycemia or diabetes. Weight reduction of 5 to 10% can prevent progression from pre-diabetes to type 2 diabetes. This type of weight loss can be achieved with lifestyle behavioral therapy alone or combined with anti-obesity medication. So this is the first step for the, you can say, for overweight patient or with the obese patient with BMI less than 35. A weight reduction of 15% or greater lead to even more glycemic improvement, including diabetes remission that we have discussed. And this type of weight loss can be achieved with more intensive lifestyle intervention like low calorie diet and exercise and new anti-obesity medication, that is GLP-1 agonist, and the metabolic and bariatric surgery, that is the last resort and the best choice in selected cases. So this is for today, and thanks everybody for the listening. And I hope we have discussed something that is very relevant nowadays. And as we have discussed, not only we have the statistics or data of US, but we know in our subcontinent, India, Pakistan, Bangladesh, it's also a major issue. Obesity, overweight, diabetes, all these things are very closely related, and we have to treat them very well. Thanks for your time, and thanks Darshika, and thanks Doc Plexus to giving me this opportunity to discuss my presentation today.
Thank you so
Okay,
much,
thank
sir.
you.
Can we take a couple of question answers, sir?
It's okay.
Yeah. So I have two, three questions. So
Okay.
my first question is, just a second. Yeah. So according to WHO, obesity has reached epidemic proportions worldwide. What is that the government can do to make people healthy? So any suggestions on that, sir?
See, again, government, before government, everybody has to understand because, the first step is, considering obesity. Okay, there are many factors, but one of the factors is food. As we see again from the treatment point of view, lifestyle changes and diet. So that is everybody's responsibility. So government cannot do anything, they cannot guide you for the diet nowadays, it's the time of internet and the knowledge, guidelines, and advices. It is available to everyone. Everybody is having a smartphone and everybody has access to YouTube, all this thing. So okay, government has also responsibilities, but I will say that the first step is everybody has to watch their own health, you know what should be the best diet, exercise, these things, and to keep screening for diabetes and all these things, metabolic syndrome, and be in touch with any practitioner. Regarding government, once who somebody is diabetes, is having obesity, and he's really fat, I mean, is already they have tried. So the medication point of view, the standard. So that is the government responsibility to if a medical practitioner is prescribing the anti-diabetic medications, that or the injection, the GLP-1 agonist. So how they can arrange, because all of them are costly medications. So I cannot it's difficult to point a government to give a treatment or medication for obesity, but diabetes is a disease, and that is the responsibility of government or medical practitioner to treat them well. Again, if you are treating well diabetics, so automatically you are targeting their weight and counseling them. So the first is everybody has to watch their own weight and diet, and then later on they should be in keep in touch with the practitioner, taking guidelines. So, and it's it's not a simple thing.
Of course, I think what you told about screening, that which is very important for such diseases. I think lifestyle
Yeah.
diseases. I think the government can play a role wherein they can have such more screening programs at remote areas also in the country, worldwide. So I think that way it could help.
Yeah.
Moving on to my second question, sir. Now, so when a patient comes to the clinic for weight loss, how can physician guide the patient with a structured lifestyle support program?
Yeah, again, as you know, as we discussed the management from this presentation as well. So the first is behavioral modification. This is the first thing. So automatically, this behavioral modification will lead them to understand what is lacking, what is missing. Again, it own diet and exercise. So this is the first thing that so like first the patient or someone, because in our society many people still feel like the obesity, if somebody is rich so he is obese. So this is a previous concept. And was a time like obesity is considered something healthy. So now the time is changed, so it's okay. But obesity related complications, so again, as a practitioner, we have to counsel them, we have to tell them, we have to change their lifestyle, their diet, their food, give time for walking, jogging, all these things. So, I mean, it's fine. Like, if the overweight, we can take them a light counseling, that it's okay with the decreased calorie intake or diet exercise. They can sure achieve a good weight and prevent the complication. But someone who is really obesity, BMI more than 30%, so we have to counsel them. So all the patients are different, so we have to counsel them accordingly.
Correct.
And
All right. So these were the questions that I had. So I think with this we can close today's program. Thank you so much, Dr. Jamil, for being here and being a sport presenting on such an important lifestyle disease problem. And to our dear audience, thank you so much for watching. If you have more questions, please do share with us. Dr. Jamil will be happy to answer those as well. With this, I think we would close today's session. Thank you so much, Dr. Jamil.
okay, thank you everyone.
Bye bye.
Bye.